A warm welcome to everyone joining us today. My name is Neha Ahmed. I'm a program consultant at CaiHi, and I have the pleasure of being the moderator for today's event. I'd like to thank you all for joining us for this discussion, and we really hope that you leave today with a better understanding of what frailty is and the resources available to you and your teams, and how you can better support care for older adults living with frailty. According to recent CaiHi data, over a third of hospitalized patients age 65 or older are at risk of frailty. And in our communities, it's estimated that over 20% of older adults are living with frailty. And we know that people with frailty have complex care needs. So to shed further light on this issue, I'm really pleased today to introduce our panelists. So first off, Dr. John Muscedere is a professor of medicine, intensivist, and clinician scientist at Queen's University and the Kingston Health Sciences Center. He's also the scientific director for the Canadian Frailty Network. Dr. Muscedere's research focuses on improving outcomes by generating new evidence and knowledge translation through clinical trials, systematic reviews, and meta-analyses, focusing on nosocomial infections and frailty. Next up, we have Dr. Grace Park, who's a family physician and the Regional Medical Director for Home Health and Specialized Community Services for Complex Medical Frail Seniors in Fraser Health Authority. She has been involved in research on frailty prevention and implementation of care to support seniors to age in place in the community through the CARES model. She's also a clinical assistant professor with the Department of Family Practice at the University of British Columbia. And next up, Tara Sawchuk is an RN, Senior Practice Consultant for Alberta Health Services, Provincial Seniors Health and Continuing Care. She worked in cardiology, emergency, and other areas before becoming a clinical nurse educator for an inpatient geriatric rehab program. She now leads the AHS Clinical Innovation and Practice Supports Elder-Friendly Care Program. And Ron Belano is an advocate for dementia, caregiving, aging, and research communities. Ron has been a caregiver to his father, who lived with Alzheimer's for over 10 years. He's an active member, advisor, and mentor to numerous organizations and educational institutions, such as AgeWell NCE, the Center for Aging and Brain Health Innovation at Baycrest, and the City of Toronto's Senior Strategy, among others. So we're really pleased and excited to have all of these experts with us today. And we'll start off, John, with you, just to lay a bit of groundwork. Could you please describe what frailty is and why it's important to consider when thinking about care for older adults?
Sure, thank you. That's a pleasure to be on the webinar. So frailty describes a state of increased vulnerability, reduced function and health in older adults. One of the more key things about it is that when somebody is frail, minor stressors can trigger a major change in health. So for example, an upper respiratory tract infection in somebody who's not frail can be, you're sick for a few days, but then you quickly bounce back. Versus in somebody who's frail, it can trigger major changes in health. It can make them go from independence to dependent, and then the recovery tends to be longer. Frail individuals are increased risk of hospitalization, readmission, institutionalization, such as long-term care, and have increased mortality. And the other aspect of it is too, when frail patients have medical conditions or medical procedures such as surgeries, their outcomes tend to be much worse than those who are not frail. The other key aspects of frailty is that it's dynamic. It can be influenced by care and support services in place. It can be prevented at times. It may be reduced. So frailty, once it's there, is not a static thing. It can change depending on what the individual is doing, but it can also be made much worse. So for example, somebody is hospitalized and put on bed rest. They may never, may become much more frail and not recover for that. And frailty is not an inevitable part of aging, and some people survive well into older ages and never become frail. And it's important to assess frailty to identify patients' vulnerabilities across multiple domains, and then put targeted strategies in place. And I'll finish off there.
Thanks so much for setting out that description of frailty, John, and how it impacts people, and also the importance of sort of assessing a patient's frailty across multiple domains and sort of thinking about it that way, thinking about it as a dynamic process. And so, Ron, I'll move on to you next. You have experienced what it's like to be a caregiver to a family member with Alzheimer's. Could you tell us a little bit about the barriers you faced when trying to navigate systems of care and how maybe a frailty program could have impacted your experience as a caregiver?
So, hi everyone, and good to meet you all again. Even though my father has passed away a few years ago, I've had the opportunity to actually chat with many caregivers across Canada. So, my story, as I share one story, it's not the only one out there. So, I've heard many similar stories. For our family, my father was not assessed formally. And I'm not sure what formally would be actually for frailty, even to this date. It was, I'd like to say, scattered pieces of information depending on the day, depending who we were talking to. And you don't know what you don't know. And you're not realizing the information that you're getting actually is quite valuable if you do get it. So for my dad, he had multiple medical needs, dementia, diabetes, heart condition, and numerous other ones that we weren't really aware how that will affect the quality of life of not just my dad. And I'm going to bring in also the caregiver to this conversation because frailty does not just affect the person living with these challenges, but it's also the people around that person. For us, navigating the care system, or the healthcare system, we were running around here and there. I was doing most of the work with the help of mom, and trying to figure out the logistics of who do we talk to, the follow-ups, like when do we follow up with a specific expert. That was quite challenging, and that added to, let's say, my dad not living the best life during, especially the early stages. It was quite challenging, which many of you, I'm sure, here, if you take off your healthcare hats, your research hats, whatever those hats are, you all know as family members, as caregivers, as friends, what I'm talking about here. For me, I look forward to some kind of frailty program, like something that's more consistent out there. And by having something like that, that will support, let's say, the patient as a whole. It's not just here's another person coming in. It's actually understanding who my dad is, the person-centered care piece that I'm interested in. And that is something that I look forward to in a frailty program to kind of say, you know what, this is what your dad's trying to pursue in his life. This program will help him, or understanding what may be coming, those challenges. If we had something like that earlier on, that would help us be more proactive. One last thing I want to talk about is some of the gaps, that I've noticed. The gaps of the navigation piece. Many times, patients, we think it's all coming from the family doctor. But in that short window of time that we have with that family physician at an appointment, we don't have time to have that discussion, right? So sometimes, well, I wish it would come from the doctor, but they also don't have that time sometimes to support us and say, hey, by the way, pay attention to some of these things that might be happening to your dad. This is where this journey might be taking you in the future. So I don't know who that is at this moment. That is it the doctor? Is it the pharmacist? Is it the person at the front desk that will give us some of this information? That's something that I'm interested in moving forward with as we move this down the road in the future.
Thank you for sharing those insights, Ron. And it's so important to remember that frailty doesn't just impact the individual, but also their caregivers, their families, their communities as well. And so our next panelists have some experience working on frailty programs. So I'll pitch the next question to both Tara and Grace. can you tell us a little bit more about how you're addressing frailty in your work? How does the understanding of a person's level of frailty change your care approach? And can the right supports change the trajectory for patients at risk? So, Grace, maybe I'll start with you first, and then we'll move on to Tara. And Grace, I think you're still on mute.
Sorry about that. Hello, everyone. So I'm a primary care provider by background, and I started working in the community, trying to address frailty with my family practice colleagues, really trying to raise awareness about what frailty is and the possibility that it can be assessed, identified with a standardized tool, and then measured to see how frail a person is using a comprehensive geriatric assessment. So we ran a small research program with a cohort of about 50 older adults among several family physicians in our communities in Fraser Health, and provided an electronic comprehensive geriatric assessment, which would open in the patient's EMR when a physician would interact with the patient in the office, and would run a comprehensive geriatric assessment and actually measure their frailty index, identifying where they're at in their frailty trajectory. And then we enrolled our older adults into a program in the community, the intervention, where they were supported by telephone peer coaches to develop a wellness plan to address their activity, to enroll in exercise activity, and to socialize. And over a 6-month period, the coaches would continue to call and motivate them and remove barriers for the older adults. And after 6 months, another assessment was done. And we found that there was a 3% improvement in their frailty index, which is pretty significant. And it was found to be statistically significant, and we were able to publish on that. So the big message is that frailty is dynamic, as John said earlier, and the message to the family physicians to talk to their older adults that you can fight frailty through healthy aging. So with that, we also recognize that there are social indicators that get in the way of healthy aging. And that's where we partnered with our community-based senior service organizations and United Way to provide a social prescribing program. And we developed the social prescribing program fashioned after the model in the United Kingdom, where the community organization would find and hire a community connector. They're called link workers in the UK. We're calling them community connectors here. And the community organization would hire this person who's not a health staff or health individual backed by background. And then they would receive referrals from their primary care community partners. And so a family physician would identify a person who's socially at risk, and they would make the referral, and they would put in the requests for the consultation with the social prescribing scheme with broad indicators like food security, social interaction, exercise promotion, caregiver support. So those are the 4 areas that we asked the family doctors to identify. And then the community connector would contact the older adult and often their caregivers as well, and hold an in-depth interview. And by talking to them and following them over a period of anywhere from 6 to 12 weeks, they identified way more than what the initial consultation request was for. They identified barriers to accessing community services like transportation, finances, cultural issues, language barriers. So all these things were issues that were not really in the realm of the health, and so family physicians weren't aware of them. But in the social sector, the community connector had access to volunteers and other service organizations that would overcome these barriers. And so that was the success and the ability for the community sector to support older adults and their caregivers. And then when they were able to participate, we know that they were able to make a difference in their ability to prevent frailty. But for those that were more frail, we would connect them to the health authority services that were already in existence. But we had it as a continuum so that if they were not able to self-manage, not able to be supported in the community, then they would be referred on for home health services, home support services, respite, day programs, etc. So it was a whole spectrum of services in the community. Thanks.
Thanks so much for that description, Grace. And Tara, maybe we'll move on to you next.
Sure, thank you very much. I guess I'm going to talk about the process we've used trying to introduce frailty assessment and follow-up, specifically in acute care. So well before COVID came, we were doing some pilots, and we had some guidance documents now within our provincial healthcare system about frailty, to try to provide some guidance about what is frailty and what can you do with it when you assess it. And we trialed the clinical frailty scale and Edmonton frail scale. We were able to get data from the system, and we know that the clinical frailty scale is already being used right now, but the Edmonton not so much. And when we look at where the clinical frailty scale is being used, that's usually the ICUs or people with expertise, geriatricians. They know how to use that scale. When we trialed both and we gave teams the freedom to pick either one, we found people had more success with the Edmonton frail scale. And we attributed that to the fact that these were people without geriatric expertise. They didn't not necessarily have full access to a complete assessment. They weren't doing full med reviews. This is a bedside nurse doing an assessment as part of their admission. And that's what we wanted. We wanted admission assessment done early. We wanted frailty assessed early so that we could address it preventively. Depending on the score from the Edmonton Frail Scale, if the score is high, then the person's at higher risk for frailty. And one of the recommended results of that is that we recommend a geriatric consult. Now, lack of geriatricians means this is not always possible for everybody who qualifies by virtue of their score. So then second best would be, well, let's do a really great team approach following the recommendations of a comprehensive geriatric assessment. And the other scenario would be where a person's not really moderately or severely frail, but there's a couple red flags. Well, then the team can likely do some very simple common sense interventions to address those flags. Polypharmacy, let's do a med review. Incontinence, let's watch their toileting and support their continence. So the team approach is really the big thing, bringing in the right person at the right time and supporting that conversation within the team to highlight the needs of a person who is living with frailty. And we also are highlighting that the patient and the family are also, they're kind of the core members of that team. It's all about them. So we can have the best ideas and the best plans, but if it doesn't fit with their goals and their abilities and their desires, it doesn't really work. Regarding changing the trajectory for patients at risk, this is definitely something we have seen. We had a story shared from a team that did a frailty assessment, found the person was at high risk, consult to the geriatrician. And the geriatrician was just flummoxed. He didn't know why he had been consulted. And they said, oh, no, the patient is fine now, but we're afraid that tomorrow they won't be because of this and this and this. And we are afraid delirium and falls, etc. He was just gobsmacked. And they said, well, what do you want me to do? He said, just give us some great recommendations so we can prevent anything from going wrong. He did. They were pretty common sense things: hydrating, mobilizing, toileting. And the person went home without any adverse experiences. And that was what sold that team on the value of focusing on these things early. And the assessments allowed the interventions to be actually much simpler than ongoing consultation with the team and experts after things have gone sour with the patient and they've really declined. One comment, just talking, Ron mentioned the importance of the family. And we're even trying to change our language to make this work quite family and patient-centered. We had one patient say, when we were talking about his level of frailty and you are frail, he said he really didn't like that. He felt like it was labeling him, and he perceived that as we were talking about him as if he was morally frail. So we realized we talk about social frailty, physical, physiological, cognitive frailty, and he interpreted it a completely different way. So we're just trying to kind of, when we talk about it, it's an aspect of the person's being. It doesn't define them.
Thank you, Tara. Those are such key points that Tara, you and Grace, you shared as well. And thank you for providing more information about some of the tools and the services and the programs that you've worked on and designed and deployed, because I feel like those are really, really helpful for our audience as well. So Ron, I'll jump back to you because you spoke about the gap in knowledge from the patient and the caregiver perspective, maybe even from the provider perspective in some cases. Do you have any ideas of how we might be able to proactively tackle awareness on this issue in a way that could be helpful for patients and caregivers?
Yeah. So Neha, the key word there is proactive that I want to throw out. That's actually the answers in the question that you just said is how to be proactive versus reactive. I sometimes feel many people, this is not just from the healthcare system side, but just family, us, we live life, and then we just become reactive when something happens. So it's trying to get more upstream is what I'm interested in, and promoting that, the awareness of getting ahead of this. And part of that for me is how well do we tell the story? How well do we promote it? What's the language that we need to use, as Tara was just saying, to the community? It could be it should be something that is comfortable to affect the way we live our lives. To say, hey, this is how you could be more proactive so that you don't become frail. Or if you are frail right now, let's see how we could reduce it so it's not going to be as painful as it could be in the future. So that's something that I like to push in the healthcare system, that everyone needs to learn how to market and promote better the work that's happening. So that's one piece. But what do we also promote and market? What Grace was talking about for me has to do with the teams, the healthcare teams, and also these community connectors. Okay, to me, they are key. Again, I said earlier that I don't think that person is specifically the family physician at that time. I don't think that physician can give us all that information when they're dealing with something else in the limited time that we have. So it's supporting some of these connectors, creating those programs, scaling it up. What Grace is sharing, I didn't have that in my community. I don't even know if it's still there where I live. So those teams is what I'm looking for to promote that there. Terry, you mentioned about the family piece, that they're at the core, the family and the friends. Yes. So it's not just, again, in my opinion, that it's just the people that get paid in the healthcare side. This is to help support the family and the friends in creating systems and programs and services or strategies. So many of the families that I've seen that have done really well are the ones that actually have monthly meetings together. Okay, so they're family and friends that say, hey, let's get together. We have our meeting, talk about mom or dad, and many times mom or dad will be there as well and say, okay, this is what we need to take back to, you know, our care when we go to the meetings with our connectors, with the navigators. So we need to kind of promote that communication piece, that we got to talk about it a lot more. So that's pretty much, I could go more and more here, but that'll be another hour of so many ideas. But I really believe simply just talking about it better and communicating it better and promoting it better is a big deal. The proactive piece.
Definitely, Ron. Thank you for that, and definitely agree on the emphasis on the proactive there too. So, we mentioned at the beginning that frailty is a growing health system challenge, and this adds, extra system pressures and competing demands for resources on the system as well. So, taking that systems view, maybe I'll move back to you, Grace, with, how do you think health systems can be better structured to successfully support people living with frailty and complex medical needs? And you might have to get off mute again, Grace. We can't hear you.
Yeah. So at the systems level, I think it's really important that we recognize that frailty crosses all sectors of the healthcare journey. So we need to follow the patient where they're at and really do that preventative work that Tara spoke about. And recognize that for frail seniors, transitions are extremely difficult. And transition, especially from acute care setting, hospital setting, back home into the community, it can be really, really fraught with difficulty. And so at a systems level, ensuring that there is support and guidance for a smooth transition, I think, is really critical. And at Fraser, we're starting a thing called PODS, Patient-Oriented Discharge Summary, which I think is really innovative. And traditionally, discharge summaries are very specialty-oriented or acute care focused and doesn't really address social needs. And so the most important thing to an older adult may not be their disease and their drugs. It may be who's going to get me food, who's going to let me into my place, where's my landlord now, who's going to get my pet who's being looked after somewhere else. So these are things that are are patient-oriented. And so we want to address those things along with the medical needs as well. And so patient-oriented discharge summary then addresses all of that, is more holistic, which is important. And at the systems level, I think we have to have policy that will support alignment between funders and different organizations to come together and work proactively and be very upstream, as Ron was saying. So in our social prescribing scheme, we had the funder, the Ministry of Health, provide the grants and the supports that was administered through United Way. And that partnership between Fraser Health and United Way and the divisions of family practice, the primary care providers in our region, we got together and we were able to work with the community-based organizations to select one that's going to house a social prescribing program in each community. So that alignment allowed us to pick an organization that was used to working with United Way, used to working with family physicians and health providers in the community so that we can actually move forward the social prescribing program. And the other thing at the systems level, I think that's really critical, is to do everything we can to promote health literacy. If we can empower our citizens to know more about their health, about healthy aging, how they can prevent frailty with the knowledge that we have now, the better we're going to be in preventing frailty and having a healthier older adult population. One more thing is at the primary care level, we have to introduce team-based care. And Tara spoke about it in adult and in acute setting, but in the community setting, primary care practitioners that are solo or in a clinic and just minding their own panel of patients cannot do frailty prevention all by themselves. So working with a team of allied health professionals, nurses, pharmacists, social workers, that allows the team to address different portions of that comprehensive geriatric assessment and care plan appropriately so that you can actually do a fulsome frailty preventative care model.
Thanks so much for that, Grace. And those reflections on that system level are also so important to consider. And I just, again, with that systems level hat in mind, I'd like to move on to John. If you could speak to us a little bit, John, about the depth of that system challenge that we're facing, and some of the approaches that are currently in place and how they would play out, but also how we might begin to take action on this issue. John, I think you're also still on mute. We can't hear you.
I'll always do that. So the systems challenges stem from an increasingly older population, and the number of people who are expected to become frail over the next 10 years is going to rapidly rise. And that's in the face of what we currently see, which is a system that's been really challenged after the COVID pandemic and has really not gotten back to where it was before, or maybe just the COVID pandemic highlighted some of the deficiencies that are in place. And so the place to first start to understand what the system challenges is to think about what seniors want. So the majority of seniors want to age well and in place in homes and communities that are of their own. They want to be able to choose the where they live and the structure of their living arrangements. But what we have is the opposite, that a lot of people, as they get older, they experience frailty or functional limitations, are institutionalized and go into long-term care, or many people wind up in hospitals and then are designated as alternate level of care, that they can't go home because there's not enough community support and they're waiting for institutionalization. And the other challenge is that at the rate that our population is increasing, the number of older individuals, we can't really hope to keep up with the demand for long-term care beds. So we really need a dramatic change in how we think about aging. First of all, Canada spends much less on home care than any other countries, and that would be a start. But then we also have to start to think about what the transformation in aging would be in Canada. And the most important thing there would be to adopt a preventive holistic approach to aging, where we promote function, where we promote reduction of frailty or prevention of frailty throughout the lifespan. And some of that starts, so that doesn't start when somebody is already frail. That starts when somebody is approaching their 50s and 60s through adoption of appropriate lifestyles. And at the Canadian Frailty Network, we've been advocating something called the Avoid Frailty, which stands for promotion of activity or exercise, vaccination, optimization of medications, and appropriate diet and nutrition as a preventive measure for frailty. And adoption of those things which are evidence-based can actually promote healthy aging. And also promoting system change within healthcare such that targeted pathways are put in place for when people are frail is going to be really, really important. So maybe I'll stop there.
Thanks so much, John. That was a really sort of great summary of some of those like big health system challenges as well, and how we might kind of think about them moving forward. And so speaking of system challenges, Tara, you had mentioned the frailty assessment sort of being provided to patients 65 and older. And, it seems like many jurisdictions don't routinely do those frailty assessments. It's not the norm for older adults. Now, do you think that the net should be cast even wider to include even more patients in these assessments?
I just love this question because one of our pilot sites where we were using the Edmonton Frail Scale, we had staff come to us and say, why can I only do this on 65 and older? They were in inner city hospital, had a lot of people who had hard lives. And we said, gosh, I don't know if it's validated for younger, but why not use it as a care approach and see if it helps? I'd love to take that back to the geriatrician who kind of started this assessment. And when he heard, he was very happy with that. And he actually told me that the Edmonton Frail Scale is now being validated for decades down. So I probably he's done 55 to 65 now, because that was in the works months and months ago. And he's planning to take it down by decade and validate if it's appropriate assessment for younger ages. And we know that frailty doesn't just suddenly click when you're 65. We stress that age is a risk factor for frailty. It doesn't equal frailty. And a lot of frailty exists across the adult lifespan and even younger. So our official process right now to start rolling this out in our province, we're focusing on 65 and older to keep it simpler. But we have CHF and COPD and cirrhosis pathways, care pathways, that have specifically embedded this as part of their admission process. And we also recommend that if you as a care provider notice a component of frailty or a geriatric syndrome, that you go ahead and you go ahead and you do the assessment there, because they're already, like Dr. Muscedere said, leaning into that frailty status, and maybe we can reverse something now by addressing it early.
Thanks for that, Tara. And I think just kind of sticking to that theme of frailty, maybe Ron, we'll move on to you next, just in terms of your thoughts on the system level changes that might be helpful to better support patients and their caregivers.
So coming from the perspective, again, of a patient caregiver, for me, I mentioned some of it earlier, and John hinted to this as well, is that I'd like to push forward the narrative of aging. What is it that we're communicating out there? Because again, Tara, as you said, when you say that number 65, is that the magic number where now we're dealing with some of these challenges? Is it 60? Is it 55? I look at it as pretty much, how do we age well? Okay, so that narrative of aging well is, in my opinion, the communication that has to go out there. And how do we do that within the policies and the systems is how we share with the community. So aging well is, again, one of the groups I'm connected to is Age Well, Canada's Technology and Aging Network. So it's in the messaging that we promote a lot. And part of that as well is having a frailty assessment that's been shared here as well, and making that let's say, I don't know, if that's just done when you're 65, Tara. That's the thing, right? It's one of those where I would love to do it whatever age people feel that they should say, hey, you know what? This is something we need to be more proactive at, and it doesn't matter what age. Honestly, I'd love to even see a 20-year-old do it just for fun. But Grace, you mentioned navigators again. I'm coming back to the navigators. I really believe that is huge. That is the key, that we need many more navigators, many more within the systems. I think I'm leaning towards social workers, okay, because Grace, some of the stuff you're talking about to me is like social determinants of health conversation piece, that it's not just, someone's physically frail and all that stuff, but a lot of these social pieces affect that along the way. There's cultural conversations we need to have as well, so that what's the goal of my dad who's Filipino, who wants to go to church? That's his quality of life. So even if you're frail, no matter what we're dealing with, is how do we support my dad more on that, as to saying we're going to find a way so you can have that spirituality, that piece of that in your life. So it's really around understanding the person is a big deal for me, that understanding their stories, the narratives of what they want to lead in their life, even though that they're frail. Okay, so it's not about wiping it out and saying, Dad, you're going to be as healthy as you can in the future. But no, this is what you have. And how do we reduce that so it's not as painful moving forward and you can still achieve what you want to do in your life? So how we do that in the systems and the policy, that's again, a lot of it is the narrative, in my opinion. So I'll keep pushing that messaging forward.
Yeah, and that's such an important point that you made there, Ron, in terms of, what does the person want? What are their goals? And really thinking about that. And also thinking about that systems level in terms of making it easier for people, using those navigators, making it easier for people to navigate these systems of care. We'll move on to maybe a question about, healthcare providers. So, just in terms of, how well healthcare providers understand frailty. So, how well is frailty understood by providers, including the use of these frailty assessment tools that we've mentioned? And what are the barriers to identification of frailty and the strategies that you've employed to mitigate these barriers? Because I think that conversation around providers is really important too. So maybe, John, I'll pass it back to you to start us off on that.
Sure. So I think from a healthcare provider point of view, there is a general lack of awareness, and I was interested in the poll at the start of this webinar where a lot of people had some familiarity with frailty, but I think that just selects out an interested population group that's participating in this webinar, probably doesn't generalize out to a whole group of healthcare providers. And some of that stems that frailty is seen many times to be a geriatric domain, or something that only geriatricians deal in, and which is not really the case. And in Canada, one of the big markers of our healthcare system is that we really have a lack of geriatric specialists. There's a very few geriatricians, advanced care geriatric nurses. And so that becomes a barrier in its own right. The other problem, and it's both a success and a barrier, is that there's many frailty tools to choose from. So in the literature, there's about 30 tools that have been described. Some have more evidence than others. In Canada, the Edmonton Frail Scale, the Clinical Frailty Scale, and were developed here in Canada. Those are probably the ones that are used the most often. They're easy to apply. They take minutes. They don't require a lot of training. So I think those are probably the ones that we should probably use the most. A comprehensive geriatric assessment is the gold standard for the identification of frailty, but that takes a lot more time as a holistic assessment of a person. It can be done by non-geriatricians, but a lot of times it's reserved for geriatricians. Finally, the other aspect to this is that one of the key messages is that frailty is not done, assessment is not just done for the assessment of frailty. A frailty assessment should lead to further care planning as to what is driving the frailty, or why is the person frail, and what can you do about those things. We at the Canadian Frailty Network, we've developed an online training module that's free. It's available to everybody. It's at www.cfn-nc.ca. I think a link is going to be distributed after this, but I encourage anybody who's interested in frailty to take the frailty module. It's easy to do, and it's freely available, and it goes through some of these details.
Thanks very much, Ron. Or sorry, my apologies, John. And maybe Tara, I'll pass it on to you for some of your reflections as well.
Sure, thank you. I've got to say, Dr. Muscedere, I've spent a lot of time on that module, and I love it. I'd say I'm going to kind of come across to share some of the barriers that I see when we're trying to implement the concept of integrating frailty in your care team. There's a lot of myth busting to do. There's kind of I know frailty when I see it, but when you ask what is frailty, not quite so sure. Or the idea that whatever it is, it's set in stone. It'll only get worse because this person is complex and old, and I'm not going to change that. That it's normal because the person is aging, so it's a normal thing. Or if the person's younger and they're really complex, of course they're going to be frail, but they don't think that it's something that we have impact over. Sometimes I don't work in long-term care, therefore I am not a geriatric specialist. Therefore, this is beyond my realm. So we have to really kind of change language sometimes. One of the triggers to do the frailty assessment was the presence of geriatric syndromes. So I talk about geriatric syndromes, and then I reframe them as these are all components of frailty. What do you see these things all the time? So then I kind of shift it and try to actually avoid the word geriatric a lot, because people are saying, I'm a medical nurse, I'm a surgical nurse, I'm not a geriatric nurse, but they are. And another strategy for that is to actually show them their statistics. This is how many of your patients are 65, 75, 85. So you must be a geriatric nurse, because if you had 10-year-olds here, you'd call yourself a pediatric nurse. So you are, just because you work here. And I actually do believe that people get kind of vaguely the concept of these are some extra vulnerabilities this person has. We try to stress that these vulnerabilities are something potentially very different from the admitting diagnosis. And we still in acute care are quite focused on the admitting diagnosis and standard care for that admitting diagnosis. So we're trying to make standard care those common sense things often that kind of are not as prioritized as the standard care for your COPD or your central line, things like that. Mobilizing that person with the central line, although it seems very basic and obvious, it's not at the same level as prioritization as wound care. And that is where things start kind of breaking down. So changing the culture where providing a mobility event or mobilizing a patient is just as important as getting your medications out is often challenging, because it's just not seen that way within the medical model a lot, or in our acute care hospitals. But with our aging population, where these are the interventions that are so critical, if we don't do them early, then we're going to really chase trying to make them effective later. Having that shift and having people see that they do have the power to influence frailty is that's the biggest payoff. That's where we have to say small investment for a big payoff.
Thanks so much for sharing those insights, Tara. And there's so much to really think about in there in terms of, some of the things that you shared. I just want to make a quick note to the audience that we're kind of approaching the last 15 minutes of our webinar. So if you do have any questions so far, please, I can see some of them trickling in through the Q&A, so please put them into the chat. And then maybe, Grace, I'll pitch the question to you in terms of, frailty and healthcare providers and some of your thoughts on that.
Thanks. as others have said, with the aging population, frailty has to become everyone's business, not just the geriatricians or the geriatric nurses. And coming from a world of primary care, we can see people as they age. We can actually see their health deficits as they accumulate, as they age. And if we try and address them in a holistic way, we can actually prevent those deficits from accumulating, which reduces the likelihood they're going to be more frail. So we've done that with the community primary care providers. Using our CARES model, we had geriatricians come and speak about frailty, the geriatric syndromes. We talked about the geriatric assessment tool and how to do them. We have a video that we make available that Ken Rockwood actually made for us that shows how to do the geriatric assessment. But currently we're working on a Center for Healthy Aging through the support from the Canadian Frailty Network. And we've got common geriatric syndromes, aging information on there for older adults and their caregivers. And we've also developed an education module based on the AVOID framework that John talked about earlier for all healthcare providers in British Columbia. So we developed it in our health authority, but we're sharing it with all the other regional health authorities so that all healthcare providers can take this 20-minute module, learn about frailty, learn about how to screen using the clinical frailty scale, and then the AVOID conversation sort of tools, how to engage an older adult to ensure that they've done the AVOID, and that they're actually pursuing a healthier lifestyle. So we've got over 1,000 healthcare providers in Fraser that have already taken this module, and we're continuing to grow it and hope to see all of the health authorities in the province take that as well. And then we're spreading it in the community sector through this social prescribing organizations. They're volunteers, they're social prescribing people that are actually seeing the older adults can take this module as well and learn about the AVOID strategies. So it's becoming a very upstream, it's available to everyone. Everyone knows about health deficits. Everyone knows about the social deficits and how these social determinants of health can affect frailty, and more people suffer with frailty with the social deficits. So I think the education piece is really huge. And then in the health system, we're actually developing a frailty pathway to try and support practitioners through a team-based approach so that if they do identify people that are in need of certain services, that they don't have to go back to a practitioner, that social worker or pharmacist or whoever saw the individual can put them on the pathway and activate these various resources. So I think that promoting the AVOID education framework has been really helpful for us. And Fraser Health has really taken this on and promoting it in their public-facing website about healthy aging and the AVOID framework. We have a little video clip of each of the letters of AVOID and how we can enact that in our lifestyles, and putting it on social media as well, saying that we all get old, but we don't have to get frail. So that's the message we're putting out, and AVOID is everywhere. John, you'll be happy to know. Thanks.
That's fantastic. Thanks so much for your insights there, Grace. So I know that we have about 10 minutes left. I did have more questions for the panelists, but maybe I will hold off on my questions for the panelists and I will move on to the audience questions for the panelists. I see that there are a number of you who have put questions into the chat. So thank you so much for that. We'll see how many we can get through in the next couple of minutes. So maybe I'll start off with one of the questions that came in, which is it considered standard practice for general practitioners to assess individuals for frailty, or is it only done if they're hospitalized? And maybe I'll start off on that with John.
Sure. It should be that that frailty is assessed in any settings of care that has older individuals. So whether it's in primary care, long-term care, residential care, or acute or acute care. We did a project a while ago with Healthcare Excellence Canada, looking at the implementation of frailty assessment in primary care across 17 primary care practices across Canada, and using the clinical frailty scale, could have been any other scale, was feasible, and it did lead to improvements in care. So I would encourage that. But I think one of the other comments that was said earlier on is it's really appropriate in healthcare teams where you can address multiple components that may be contributing to the development of frailty. Or if you're in a solo practice, then referral would be the way to go. But maybe Grace can also comment on that since she works in primary care.
I can make a comment there. As I said, frailty assessment should be part of care. We know in parts of Europe, a person turns age 70, a nurse will go to the home and speak to them about services that they could access, etc. So introducing the notion that you might need help down the road when you need these things and you start having some symptoms of frailty. But in primary care, we can actually address it way earlier. And as things accumulate, if we have the lens that these accumulation of health deficits lead to frailty, everybody wants to avoid frailty. We will do our best to get our hearing assessed if there's a problem, do our best to work on our strength of our hip flexors because we can't get up from a chair. So all these assessments are really, really helpful for older adults. And when I was doing the comprehensive geriatric assessment, because I was a pilot site in our study, my patients are so grateful that I called them in actually to do this comprehensive geriatric assessment. And I was asking them questions about their ability to do activities of daily living or their instrumental activities of daily living, their caregiver status, do they have one? Do they have people to call? Do they have enough means to make ends meet at the end of the month? Do they have housing? Are they in need of lower income housing? All these things that we really don't talk about in medicine, but we had the opportunity because I was running this study and I said, I'm just going to ask you these questions because we want to see where you're at and see if you are actually at risk of developing frailty. And the patients just love that. And so doing it in primary care, I think, is a really great setting, but really doing it in team-based is the best because the comprehensive geriatric assessment is quite long because it has many, many domains to complete. So if you have some help with allied health practitioners or social workers in your group's practice, that's the way to go. And that's what we're trying to pursue here in BC.
Thanks so much, John and Grace, for your responses to that. Maybe I'll move on to another question from the audience. We've maybe combined a couple of the questions that came in, but the idea is, do you have a preferred model for seniors? Like this is what holistic model looks like type of thing, and how would you best integrate seniors, chronic conditions, primary and continuing care? Like what does that sort of ideal model maybe look like? And perhaps I'll pitch this one to Tara to respond to first, if you have any thoughts on this.
I think, and this is kind of looking forward what we want to see evolve, but like I said, we have a provincial system now for documentation. And that system isn't just in acute care. It goes into long-term care with variability, depending if it's a private site or an AHS site. And it also can go into PCN networks. So regardless of how much of those common elements are shared, what is going to be shared are things like frailty-informed care plan. So when a person comes into acute care and we assess, we also have to stress you're not seeing the person at their best, at their baseline. So if they're not functionally doing well right now, they can't walk. Well, it's because they got a broken hip or they've got pneumonia and they're very weak. You want to know what their baseline was when they were well. So we really want to connect with the PCN where maybe they made a frailty-informed care plan because they identified risks to the patient, or we at least can see what their norms were. And then we want to stress with the patient, do your assessment, but ask a follow-up question or think about things. If the person is not doing well with their functional capacity now, could they 2 weeks ago? Is that your goal then for mobility? So we're trying to recognize that, like Dr. Park said, transitions are huge risk points, and we can really lose salient critical information and strategies if we don't pay attention to where they came and where they're going.
Those are great points, Tara, as well. And I know we only have a couple of minutes left, but Ron, if I could get you to respond with it in like a minute to one of the questions, which is, can you speak to the incorporation of culture on this consideration of frailty? You sort of talked about what those different, maybe, those specific cultural ideas are for people and what they want to achieve, especially given Canada's growing diversity. But you only have like a minute to respond. I know it's a very complicated question.
I'll answer very quickly on that, and I do want to answer the previous question quickly as well. But for me, it's, again, culture is person-centered care, understanding where the person is, asking them those better questions. It's the communication piece, is what's important to you in your life? What do you want? And then I like to reverse engineer as to say, well, how do we get there if you're dealing with frailty? So to me, it's culture. It's not just culture, but it's all that. But I do want to just answer the previous question in my unique way about systems, or I can't recall the bottom line for me is I always look at what are the emotions that you're creating for this person? What are they looking for? Do they trust the system? Are they confident in the team and the people that's there? Okay. And you bring them hope. Okay. That's something that's very important that I think people forget, is to say, what's the feeling after you've experienced this interaction or this community? So I say, pay attention to the feelings as well when you're conversating. I think that's quite important. You'll get a lot of answers.
That's a really fantastic point to sort of close us off here, Ron. Thank you so much for sharing that. So we're at the kind of final minute or two of the webinar, and my apologies, we were not able to get through all of the audience questions. We will try to respond to them in writing post-webinar. So the questions that we weren't able to get to, we'll try our best to respond to them via email later on after the webinar. But for now, I'd like to thank all of our excellent panelists for sharing their insights and their experiences with all of us on this critical health system issue. And thank you to the audience for joining us today and sharing your questions and your comments in the chat. We hope that this conversation provided you with some food for thought and some ideas about how you can act on this issue. Just a few concluding notes. We will be sending out an evaluation, and we'd be greatly appreciative if you could provide your feedback on this session. Thank you for all the thumbs up as well. We really appreciate that. Also, as I said at the beginning, there'll be a recording of the session available to participants in the next few weeks, and you'll be receiving an email once that's ready. There were also a lot of comments in the chat in the Q&A about the resources that were mentioned. So some of the training modules and so on that were mentioned in the chat. So we'll also be sending out a list of resources after this webinar to all of the participants. So hopefully that will help you access those resources. So thank you, everybody, and have a great rest of your day. Bye-bye.